Dear audience, let me present my PhD thesis, The Management of Cervical Insufficiency. My name is Leila Tigharghar. I'm a resident doctor at the Clinic of Obstetrics and Gynecology at Semmelweis University, and my vision is to make cervical insufficiency an easily manageable disease. And my mission is to find the most effective treatment for it by applying up-to-date scientific results. I have two ongoing projects at the moment. The first one is investigating the efficacy of different therapeutic modalities for cervical insufficiency on the prevention of preterm birth. It is a systematic review and network meta-analysis. Just a little bit about cervical insufficiency. It's the inability of the uterine cervix to retain a pregnancy, an asymptomatic dilation of the cervix in the second trimester. Its incidence is quite low in the general obstetric population, but it is 8% in women who had a history of mid-trimester pregnancy loss. Risk factors can include conization of the cervix, inflammation, laceration during a previous birth, or just the structural weakness of the cervical tissue. Despite having such a low incidence rate, it can have serious consequences, including preterm birth and mid-term pregnancy loss. The treatment is quite simple. It's either pessary, cerclage, or progesterone. They are easily accessible, but there is no conclusive data on which is the most effective treatment. So our aim is to compare the effectiveness of these treatments. We posed the clinical question, which treatment is the most effective at preventing preterm birth in women with cervical insufficiency? And we investigated the population of pregnant women with cervical insufficiency. We have two subgroups, singleton and twin pregnancies, and we compared the three interventions. And our primary outcome is a spontaneous preterm birth before the 37th week or fetal death, and we have many secondary outcomes as well. Our hypothesis is that cerclage, pessary, and progesterone have different efficacies on preventing preterm birth. We conducted our systematic search in 4 databases, and the search key consisted of the population and intervention domain. So we started with over 5,000 articles, and in the end, we have 41 eligible full-text RCTs. We have one ongoing analysis, and in the meantime, let me present some of our results. So this is spontaneous preterm birth before 37th week in singletons, and this is a network plot. As you can see, there are dots. They represent the interventions, and there are lines connecting them, and they are direct trial evidence between them. The size of the dots correlates to the number of patients, and the thickness of the line correlates to the number of articles. This is a league table. This is a table of estimates, including containing odds ratios and confidence intervals. There are indirect and direct comparisons in this table, and you can see the highlighted results, which have a statistical significance, meaning that pessary, compared to standard of care, is 39% more effective at preventing preterm birth. And this is a forest plot for the twins. Because of the lack of articles, we couldn't do a network analysis for the twins, but here's a pair by comparisons, comparing pessary to standard of care or no interventions. You can see there is a heterogeneity of 2%. We have an odds ratio of 0.76, and the confidence interval is just above 1, meaning that it is clinically relevant, but statistically not significant, and pessary prevents preterm birth in twins as well. This is another network plot for spontaneous early preterm birth before the 34th weeks. And here is the league table for this outcome. As you can see, there are no statistically significant estimates in this table. But for the twins, it's almost the same as before. We have a 0.65% odds ratio, and the confidence interval is just above 1, meaning that it is clinically relevant, meanwhile not statistically significant, that pessary, compared to standard of care or no intervention, prevents preterm birth in twins. And this is our other primary outcome, fetal death. This is the network plot for it. And this is the league table for singletons. As you can see, there are no statistically significant results. But in the twins, it's almost the same as before. The odds ratio is 0.73, and the confidence interval is just above 1, meaning that it is clinically relevant that pessary, compared to standard of care or no intervention, can prevent fetal death in twins. So let me list some of the strengths of our study. We used only RCTs, and we have a network meta-analysis with a good consistency. Although there are some limitations, some studies used additional treatments. They had a different time of application for the interventions, and there is a lack of data for the twins. In conclusion, pessary is the most effective treatment so far in singleton pregnancies with cervical insufficiency for the prevention of preterm birth, and it should be considered as a first-line treatment, and policymakers should recommend it as a first-line treatment. And the implication for research is that further RCTs are needed to compare pessary, progesterone, and cerclage directly. Here is the progress on my first topic. I'm currently in the manuscript writing phase. And let me talk a little bit about my second project as well, which is investigating the cervical insufficiency as a risk factor for developing pelvic organ prolapse. It's a systematic review and meta-analysis. Pelvic organ prolapse is the descent of the anterior vaginal wall, the posterior vaginal wall, or the uterus, or some kind of combination of the three. Symptoms can include discomfort, incontinence, tissue bulging out of the vagina, and risk factors can include obesity, constipation, connective tissue disorder, and mainly vaginal delivery. The prevalence is very high, it's 40%. And treatment can be conservative or surgical. 11% of women undergo surgery, and a third might need additional surgeries later in their life. So our aim is to assess cervical insufficiency as a risk factor for subsequent development of pelvic organ prolapse. We pose the clinical question, is cervical insufficiency a risk factor for developing prolapse? We would like to investigate the population of Paris women and compare history of cervical insufficiency to no history and measure the outcome of the development of the prolapse. The implication would be that assessing the risk factors can facilitate early management and screening and help avoid unnecessary surgeries in the future. And our hypothesis is that the history of cervical insufficiency is associated with an increased risk of developing prolapse. We conducted our search in 3 databases, and the search key consisted of a population and outcome domain. So we are in the beginning stages of this project. We plan to submit our Prospero soon. And to sum it up, I have 2 ongoing projects at the moment, and I would like to submit them by September this year. And I would like to thank your attention with the words of Albert Sendjördi. Research is seeing what everybody else has seen and thinking what nobody else has thought. Thank you.
Congratulations to a very nice presentation. My question would be regarding the first project and results for twins. Did you consider to subgroup for the standard of care and no intervention? Because so far you got in one group, and in my consideration, it's quite different population.
Thank you. We decided to group those 2 interventions together because they are, in this case, we have much more articles to draw a conclusion from, and because they are quite similar, meaning that they're not well defined. So it's not a well-defined intervention.
I have one question regarding your second project. So let's assume that you find that cervical insufficiency is a risk factor for pelvic organ prolapse. What would you do in clinical practice to prevent the prolapse from happening in this specific population?
Thank you. Okay, so early management and early screening is very important in this case, and we can use conservative treatments instead of surgical ones. That's why it's so important.
For example?
Pelvic floor muscle exercises and pessaries.
All right, thank you.
As I remember, previously you said that these cerclage techniques are quite new, or not so new?
Not so new.
Okay, so do you welcome this result that actually pessary seems to be better? Because I think like cerclage may infer some risk because it's like invasive compared to pessary. So are you content that pessary is the winner?
I think personally, yeah, and I think most of the gynecologists do, because cerclage requires like surgery and anesthesia. Meanwhile, pessary can be done without it, so it's much more comfortable.
if I may just make it clear to those who are not gynecologists. So, first of all, preterm birth, that is a burden that we could not deal with. We could not do anything with it. It has been around 10% or somewhere 10 to 15 in the last 50 years. There's nothing to do with this. We tried everything, but we could not do anything. And one of the most important reasons is cervical insufficiency. And what Leila has discovered that these pessaries may diminish the risk is really a breakthrough, because we have been using these pessaries for, let's say, a decade, but no one had any evidence behind this. So this is really brand new. So we would like to submit it to the American Journal, for example, or something like that.